mental health issues are on the rise in what many call it silent or hidden pandemic. That's why I'm honored to be joined by my guest, Dr. Anusha Lachman, who is an internationally recognized adolescent and child psychiatrist. She's also the president of the South African Society of Psychiatrists. She's here to help us understand and help support children and adolescents with mental health issues. Dr. Lachman, thank you for being a guest today.
Thank you for having me.
I watched one of your videos. I mean, I was obviously reading about you and I watched one of your videos and you mentioned infant mental health. And I was so fascinated for a moment. I was like, what is even infant mental health? Do babies, assume?
Thank you for that question. I love that whenever I do talks or if I'm teaching, I talk about why would a baby need a psychiatrist?
Exactly.
And that's fundamentally the crux of infant mental health because babies don't exist in isolation. Donald Winnicott was a favorite pediatrician who said, there's no such thing as just a baby. And what he meant was that babies are part of a relationship. And that relationship is usually with a significant caregiver or an adult caregiver. And so if adults need mental health support and psychiatrists, then the baby as part of the relationship would automatically need to see a psychiatrist. And it's an interesting thing about infant mental health, which is something we kind of instinctively do on a daily basis. But when we label it, people aren't aware of what that is. And if I can break it down for you.
Yes, please.
So an infant is really from the time period of 0 to 3 in common definitions. And mental health is looking at, like the WHO says, what is your physical, emotional, and social well-being. And health is the well-being of families and systems. So infant mental health is really the study, the support, and the kind of engagement of very young babies in the context of their well-being holistically as part of a family and a system. So when we offer support and advice, it may not be necessarily that baby needs to sit in therapy, but all these factors that interact to make sure baby can actually develop optimally.
Can you just give us some examples so you can understand what factors can affect baby's mental health?
So when we look at a baby and we look at a young infant, and any child for that matter, but it's always easier to talk about babies since all of us can relate to that. You're born with a set of predetermined genetic vulnerabilities, risk factors, but also resilience, right? But that's not only who you are. You are a function of how you look to the rest of the world. So we often talk about that in sciencey terms as your phenotype. So what you look like. Your genotype is what you're born with. But infant development is an interaction, a dynamic interaction between what you're born with, what you look like, and how your environment accepts you. And that environment itself is influenced by a number of other factors. So for example, who are the people looking after you? What are their mental health issues? Or what are their psychosocial issues or determinants? And how supportive or not supportive is that environment for you? So sometimes it may have nothing to do with the caregiver, but how that infant is responded to. For example, if they have a disability or they look funny or they have special needs, how does that environment, the community, the education system, the creche, the peers react will influence how that baby develops.
Will influence the baby in the first 3 months?
Well, we talk about the first 1,000 days of life.
Yeah,
right?
Of course.
And so the first 1,000 days of life is that time from conception in utero to the first 2 years of a baby's life. And so that's a fundamentally critical period of development for 2 reasons. One of 2 things can happen. Number one is when bad things happen, it has an exponentially greater effect on that developing brain and neurocircuitry. But the good news is if good things happen, so if we intervene early, if we stop the adversity, if we're able to enhance and support development, then it has a similar effect. It exponentially has a better effect. So we focus a lot of our our kind of teaching and training and support and wanting to increase education around that first 1,000 days, because it's a critical period of brain development. So it's not just about talking and support, it's also the science supports that. And so the science says in the first 1,000 days, your neurons are basically forming connections at almost 1 million per second, right? But also your brain is specializing. So it's having these synaptic prunings, it's snipping off the good things, the bad things, it's trying to allow you to become a more sophisticated version of your brain, so that you have that higher cognitive functioning, so that you can learn. You learn about speech, you're able to track, you're able to develop your motor and sensory senses. For that to happen, there's a lot of kind of work happening in the background.
I can imagine. Yeah, of course.
And surely it makes sense instinctively that that is not going to be unaffected by other things. So if a child, you asked about examples, so if in that time, if we know this brain is working really hard and all these neurotransmitters are going on and they're working overtime and they're trying to specialize, and if you add hits to that, so what would a hit be, right? A hit would be, for example, early exposure to substances in utero. So we talk about things like alcohol use, substance use, smoking.
From that early.
Right? And all we say is, well, if you smoke, we've got literature to tell us that you are more likely to become a small for gestational age baby or your preterm delivery. But we don't talk about the other things that can happen in terms of social, emotional development. If we have a caregiver whose mental health issues are not taken care of, there's a lot of engagement and conversation happening about should mothers be on antidepressants and is it harming the brain? And let's talk about the structural abnormalities that happen. And all of that, of course, is true and we can track that. But what about not treating a mother or a caregiver? What does that do to the infant who's completely helpless, who's reliant on that caregiver? And if that adult caregiver is not well, not just physically, mentally well, then we have to basically weigh up the risk and benefit ratio of treating versus not treating. So all these are considered hits.
Wow.
In the early first 1,000
I read
days.
something about ACEs.
Yes. So ACEs are adverse childhood experiences. And so there's really good evidence to support that if you have more than 2 early adverse events.
Which is abuse, neglect,
exposure to poverty, untreated mental illness in a caregiver, food insecurity, trauma, basically in a variety of forms, even physical sort of exposures to things. So you could be in a car accident, or you could have sort of a hypoxic episode or things like that, right? Or near drowning, those kind of common things that people know about. So all of those things, if they add them together, as you increase the number of ACEs, there are studies to show that the long-term outcomes in terms of physical health is affected. So
physical and mental.
Exactly. And that's the point, right? So we think it's just airy-fairy soft mental health. But actually, if you are under the age of 10 and you have more than 2 ACEs, right, you are more likely to later on in your life, say 20 to 30 years later, have higher risk factors for particular physical health outcomes like cardiovascular disease, substance use, and cancers. So basically, that's a landmark study. It's called the ACEs study.
Yeah.
You correctly know that. And so, yes, of course, mental health outcomes are bad. But physical health outcomes are also not unaffected by that. So the idea is about preventative care. And preventative care is the one thing we have control over. We can't stop natural disasters.
True.
We can't stop what happens in your life trajectory when life comes at you. But in this early age, in that first 3 years of life, we have huge opportunity to intervene in order to influence the trajectory of that brain in so many different ways. And that's, in science lingo, it's called the science of early development. And for far too long, especially in medicine, we focus a lot on, let's measure the milestones, right?
Physical.
Right?
Yeah.
So when you read these things or you're online or you're going through your social media accounts and you're saying, can my baby walk at this time? Can they talk? How many steps are they taking? Are they able to grasp things? We look about fine motor, we look at gross motor, we look at balance, we say speech and language, but we don't mention social emotional development, which is also a milestone, which is critical, and then we step back and we look at common misperceptions of things. So for example, we say, this baby's not making eye contact with me, and so he must be autistic. there are so many other more common reasons that babies don't make eye contact. And if we were aware of that, social, emotionally, what babies need, then we're able to identify early, we can screen, and we can intervene. And that's the magic. People talk about what's the magic age for intervention. And if you read it, they'll say there's no magic age. But I'm here to remind you there is a magic age. Obviously, anything that you do and you intervene along a child and adolescent's trajectory of growth and development is helpful. But there is a magic age. And that magic age is below the age of 3.
I have prepared so many questions, but there's many new more questions in my head before I get to the questions here. One of the things that you mentioned, caregiver or a mother or a parent, is there any research to show which one is better if the child is...
I love that question. The answer is no. The answer is it doesn't matter who the caregiver is, so long as that caregiver is consistent and predictable and safe for that child. And I would, if you'd let me, take the opportunity to say that we really have to step back from making mothers feel guilty about sharing childcare, about being able to facilitate childcare options that allow them to then work, allow them to look after other children, allow them to also provide for their families. And for far too long, we look and we say, a baby needs a mother 24 hours a day. Biologically, that works better than babies who are put in creches or babies who are looked after by nannies or, kind of have an au pair. The literature doesn't support that. The literature tells you what matters is the quality of care that the child has. Now, if, I often will get asked that question, doctor, what should I do? Should I get a stay-at-home nanny? Or is it better that I stay at home? And I would say, well, it depends, right? If you're at home 24 hours a day and you're on your phone and you're on your iPad and you're thinking of 500 other things, then what? Yeah. Get your au pair.
Yeah.
And get that domestic worker and get somebody who actually can give that child face-to-face reciprocal interaction, because that's what babies need. Babies learn through mimicry. And so putting a baby in front of an iPad or in front of a TV or in front of, kind of one of these devices, I would then say, what? Then you might as well have a robot looking after your baby. We did a thought piece once a few years ago with some students of mine about, could a robot rear a baby? Right? And people have a lot of thoughts around that. And they say, no, actually, it's flat affect and they aren't able to respond. And I would challenge you and say that's not true. In fact, we're so okay with not treating mothers and caregivers with mental illnesses that they have blank faces because we're obsessed with what adverse effects the drugs are going to have, that we forget that the baby is looking at a blank screen. They don't have the opportunity to mimic, right, and to respond. That if you had a robot, which as advanced as AI is at the moment, why not? Babies need to learn facial expressions. Babies need to, again, copy and imitate. So I'll tell you something else. In the brain, we have the most fascinating thing called mirror neurons.
Okay.
And mirror neurons are in the motor sensory cortex of the brain. And what they do is that they basically get activated if you watch somebody else doing an action as if you're doing it yourself. And so it's fascinating. It's called mirror neurons, motor sensory cortex. So if a baby is looking at a dog and the dog sticks their tongue out, that baby automatically sticks their tongue out. Not because he recognizes the dog, but because the motor sensory cortex is activated as if that baby's doing the motion themselves. Now just think about that for a second, how powerful that is. That if you have a parent or a caregiver or a robot basically allowing this child to look, to learn, and to reciprocally engage and copy, right? And that's what the baby needs. So back to your to your question about who should be looking after the baby. I would say if you have quality time with the baby, if that mom can only spend an hour a day, but it's focused attention, that it's reciprocal, enjoyable engagement with the baby, then that's good enough. Then a mom who's there for 8 hours a day but isn't really present in that space. I did a study on shared pleasure interactions.
Okay.
And shared pleasure is basically the ability for you to make direct eye contact and a simultaneous gaze with a smile. So, someone will tell you, how do I know you're really interested in me now, Dr. Sia? It's because you're smiling with your eyes,
Okay, I
right?
see.
It's your authentic engagement. And so babies can tell that from a very young age, what's authentic and what's not. And so what we want to do is we want to encourage that shared, pleasurable engagement bi-directionally between the caregiver and the baby so that they both learn from each other. So one stimulates the adult's ability to feel joy, and the baby learns because the baby feels that as a pleasurable engagement. And that sets the groundwork for optimal brain development. So the WHO talks about nurturing care. And nurturing care is not about stuff.
Not about sleep and food.
No, it's not. That's a basic human right, right?
True.
Children need to be safe. They need to be protected. They need to be fed. And they need to sleep, right? So that's a basic human right. So let's not confuse that. Nurturing care is attention to that child's attempt to interact with its environment and to learn. And the only way a child can do that is if there's a responsible caregiver that can facilitate that can create the opportunity for that baby to be able to learn in a mutually enjoyable way. So it can't be that you're like, oh, here's this expensive toy, you do your thing. Children have a limited repertoire from which they can learn. And so you need to enjoy it with them, right? Which is hard
It's
to
hard
do.
and to do it every day.
Correct. Correct.
For first few days, yeah.
So then let's just, realize our expectations. What are you expecting to do? No one's asking you to have enjoyable play with your child 24 hours a day, right? But depending on how old the child is, at least 30 minutes a day is what that child needs, undivided attention for it.
Well, my child is 14 and she still asks me for the same thing, So.
Yeah, exactly right. So again, why would a baby need a psychiatrist? This is why.
I was reading about psychiatry and child psychiatry, and I realized that the word trauma doesn't necessarily mean a traumatic event. Or does it?
Well, depends.
So
I mean, it's an important thing, and maybe we must talk about that in our context when we look at the world that actually is not a safe place at the moment, right? In psychiatric diagnostic manuals like the DSM, PTSD, so post-traumatic stress disorder, which we traditionally know happens when people are exposed to a trauma. So there are different criteria and categories for children. For children, they don't need to expose themselves to that trauma itself. They don't need to be in an accident. They don't need to be assaulted. They don't need to have the terrible thing happen to them. They have to have that happen to the caregiver. And if the caregiver experiences it as helpless, as hopeless, as unable to navigate and scaffold, the baby or the child can get full-blown PTSD, right? And the DSM allows for that criteria. So they don't need to experience it. Their significant caregiver needs to experience it and respond in that way so that they themselves can have pure PTSD symptoms, even though they may not have been the direct recipient of that trauma. Okay. And that's very powerful once we understand the role of the caregiver. If you as a caregiver can have such a devastating impact on the child, you can see why it's so important that our focus needs to be a lot more on who's looking after these children. And are they mentally well? And if not, are we doing enough to support them? Because whatever happens to them translates into action into the child.
And I'm now thinking postpartum depression.
Yes, we really need to talk about that as well. So with postpartum depression, the challenge is that we don't recognize it. So one of the myths, if you don't mind, is, we start saying things like, oh, all moms experience baby blues.
Yes.
It's not true. Baby blues, which basically is a physiological description of what happens in that first 72 hours when hormone surges, rise and drop. And when we have this kind of physiological experience that biological parents go through, right? That usually lasts 72 hours up to a week. And parents may have similar features of not being able to sleep, of being irritable, of being quite tearful, not quite coping. Emotionally, you expect that, right? That's true. Almost all parents go through that. If it persists beyond 2 weeks up to 6 weeks, then your red flags should be up, because then it's not baby blues. then it's basically heralding something more sinister. And what it's heralding is something that is called a major depressive episode or major depressive disorder. And let's talk a little bit about that. For example, in low middle income countries where the rates of perinatal depression, meaning starting in utero and postpartum, are 3 times higher than anywhere else in the world. So if we look at the rates of postpartum depression in Europe, that's 12%, 8 to 12%.
Okay.
If we look at it in South Africa, there have been studies that have been done in the Western Cape in RCTs, which have a prevalence rate of postpartum depression of around 32%.
In Western Cape?
Yeah. So think about it, 32%. And so what are the reasons for that? Well, the reasons are more than what you just think. It's not just about poverty, although that is a huge impact. It has a huge impact, psychosocial determinants of mental illness. But it's also about interpersonal violence. It is about poor recognition of that. It's about unpaid workloads. It's about roles of caregivers that need to happen. And the mistake we make is to think that just poor people become depressed. And that's not true.
Yeah, another myth, yeah.
That is not true. It is a mental illness. It is something that is treatable. It has devastating impacts when it's not treated and when it's not recognized. And the biggest culprits are people like you and I, or members of community or friends and family, who when mothers come and say they're struggling, what do we say? Ugh, everybody went through it. My mother had 5 children and so she got over it. What's it? True. Life is not like it used to be 30 years ago.
True.
Many of the women in low middle income countries, in South Africa particularly, are moving away from their significant support structures. So they're no longer in these collective environments where there are neighbors. I mean, do you even know your neighbor now? You know, but they're part of neighbors, aunties, caregivers in the community who can step in, who can tell you, oh, you know what, this is how you burp the baby. Or this is how you should hold it and the feeding is a little bit better. But instead, what do we have? We have mums who have to move away from their support systems to work. Usually they are isolated in high-pressure jobs or they are in the cities and they don't have the luxury of having that significant elder person or more experienced person to navigate this new kind of space for them. And so they feel isolated, they aren't able to rationalize it, they feel overwhelmed by it, and they become depressed. So it's not that they're not coping, it's that it takes a village to rear a child. And they're out of that village now. So that's one of the huge risk factors we have for the increasing rates of postpartum depression. And I want to say another thing with you. You mentioned your 14-year-old daughter. Postpartum depression doesn't only affect women, right? So there are studies that come out of significant groups in the UK from the Avon longitudinal study, but also in Australia, Stephen Matthew and his colleagues, and they talk about postpartum depression in fathers. And that's a really important thing that we don't talk enough about. That men also suffer from depression and in the postpartum period. And why we're interested is because maternal mental health influences paternal mental health and vice versa. So if a father is depressed, he influences the pregnant mother or the new mother, and that influences long-term development in the babies. So it's in all of our interests, if we are wanting to support babies to optimally grow, for us to be able to recognize that men also have significant risk factors. Because think about it, you know, we come up with so many preconceived ideas of what it's like when somebody says, oh, you know, my partner is going to have a baby, and everybody's, congratulations, you must have been waiting to be a father, and it's wonderful. And so we don't give them space to talk about the ambivalence, to talk about the fear, to talk about this mental construct of what does this mean for me as a man, where I have to renegotiate my space in this relationship, that it becomes a triadic relationship now. The father relative to the partner, relative to the child, their own sense of not being good enough or not being able to manage. Also representations. I mean, how we parent is a function of how we were parented or how we witnessed and experienced parenting. And so if you didn't have necessarily a good role model or you couldn't look out at what you aspired to be, that's very anxiety provoking for a parent. And so again, can you see why babies need psychiatrists?
My last question in this, 8 pages I told you of question, I'm going to ask it now, because what gives you hope? Because I feel like you are, first of all, mental health is a taboo even in some countries. Do you see a bright or the light at the end of the tunnel?
100%. Because the whole point is early intervention and prevention is key.
Okay. It's like
Right?
a vaccine, kind of like what vaccine
Absolutely.
does. Yeah.
And so the thing is, nothing I'm telling you now is not things we can change. Right?
Okay.
We can treat postpartum depression in men or in women. We can support caregivers better. We can screen earlier. We can flag up what are the risk factors, and we can manage that. We can look at children who've been abused, and we can take them out of that situation. We can provide better parenting so that parents don't find themselves in that frustrating situation where they have to abuse their children. We can look at the environment and we say, how do we support this environment better? Is it that we need to invest more socially? Is it that we need to have more community engagement? Is it that actually the reality is it's not a maternal instinct to look after baby? Do you know that? I want to use a really funny thing.
I was like, what?
I want to use a very funny thing. So another thing we do really badly is we make people feel bad about what they're supposed to know, right?
Yeah.
And so just look at all that kind of nonsense surveys that people take online on Facebook or whatever. And they're like, what are the 10 things I'm doing that's going to make my baby, kind of become the next Einstein? Or what can I do to make sure that my child is ahead of everything? So we give them all these unrealistic expectations where, educational kind of trajectories differ. But I want to talk about maternal instinct. So we make mothers, and I'm using mothers, but it means caregivers.
Okay.
We make them feel bad because we say, but you have a maternal instinct. Do you know where that instinct came from? Charles Darwin, in his Origin of Species, said that animals basically have an instinct not to kill their young. That's all it is. So I love to tell parents that. The fact that you are keeping this child alive means that instinct is there. It's not your instinct to be a mind reader or a magician or to know what this baby needs. What you learn. You recognize it's a process. It's a reciprocal engagement. You learn, we talk about attunement, the non-verbal sensing of what the baby is giving you. And so mothers would automatically tell you, oh, I know this cry is she's hungry, or this cry is the baby is tired. Why do they know that? Because they're attuned to the baby. But that comes over time. You can't listen to a podcast and recognize that that's the baby cry. Babies are different. They don't read the manual. But the instinct is to not kill your child. The instinct is not to love your child from birth, because that's the other thing. We don't give mothers permission to say that sometimes it's hard.
Of course.
Sometimes I don't like being a mother. Sometimes I'm not completely in love with this child. Physiologically, with oxytocin, we are programmed to have the sense of love and this overwhelming care and concern and nurturing. Nurturing for what? To not kill the child.
Well, I feel like all the babies gathered, made a union, and they paid you to be their advocate.
I mean, it's an interesting thing because, why is it that when we have infanticide, which is a terrible thing that happens, why is it that the mothers don't go to jail, they go to mental health asylums? Have you ever thought about that?
No.
The reason is because it's against that instinct to harm your vulnerable child. And if you do that, there's an expectation something must not be right with you.
Wow. Sure. That was lots of new information. Let me just take it in. Okay. First question. Why are so many kids struggling with mental health today?
I think
risk factors.
I think it's hard to be a child at the moment in this environment. I think we have many expectations that are unrealistic. So, one of the commonest things people talk about is, why are so many children on medication for ADHD? And then I ask the question, how old is the child? And what are you expecting them to do? So at the moment, children are starting school when they're 3 or 4. And they're at a desk for 4 or 5 hours, and then they're fidgeting and they're not able to, concentrate and produce and complete. And we need to take a step back and we need to ask ourselves, what are we expecting a child to do for that developmental age? At that stage, a 4 or 5-year-old should actually be running outside, should be playing with their peers, should be falling down, should be learning from the environment, learning social cues. Instead, they're at the iPad, and they're learning their timetables, and they're learning to read. And there's a place for all of that, for sure. But we're disproportionately deciding how we want children to learn. And children have to learn from more than just books. And so I feel like when we don't offer children the opportunity to learn from the environment, to learn from trial and error, to learn from failure, we set them up for unrealistic expectations and vulnerability for mental illness. So children who don't learn from an early age that it's okay to fail, that's okay to not perform, optimally or the best, that it's trial and error, have less likelihood to regulate themselves older as teenagers when they do fail, when things don't go according to plan, when they feel they're disappointing the adult expectation of what they should be doing. So I think there's many levels to why there's so much of focus on children having mental health issues at the moment. But I think one of the main things is we have unrealistic expectations of what children are supposed to do. Think of it this way. What is the job description of a child at each time?
I mean, when you started saying difficult to be a child, and I just thought of myself, which is maybe at one generation behind two. We just had no expectation. Go out, play, fun, football, whatever. Now you must know ABCDs by 3 years old.
And even, children painting, some things that are just like sort of not looking great. It's okay. If that's your child, that's what you do. Not everything has to be a Picasso, or anything like that. But maybe this is a good time to also say it's also about how people parent. So, for example, children are not given the opportunity to understand that sometimes we're not good at everything, right? So everything that your child paints, for example, a silly example, but doesn't need to be hyped up as the best thing since sliced bread.
Yeah.
Because what happens then is the world doesn't see you just like that. Not everything you do is going to be wonderful, but you have to be able to receive that critique and that criticism, because that actually builds character. It allows you to persevere. It allows you to try. And it allows you to enhance skills that you're weak at. But if you're not getting that feedback, then you're not getting that opportunity to develop skills.
So that's
that are not
something
good.
Parents do wrong by telling
Not
them
wrong,
you are.
but that they kind of overindulge sometimes, right? And so that's what happens, because then when children feel like everything I'm doing has to be perfect, then when you're an adolescent and when you now suddenly not number one or number two in your art class, then you're thinking, oh my goodness, what's happened? Is it me? I'm terrible. I'm not good enough. Nobody's going to value me. And then they have high rates of vulnerable risk factors, for psychosocial stresses, not being able to tolerate failure, not being able to regulate that. And it all really comes back from early on. What were your experiences of when things went bad? How did your caregiver respond? Were you allowed to make mistakes, right? Were you corrected in a helpful way? Or was it actually in this house, nobody makes mistakes?
That's very realistic. In today's world, many people do that.
Yeah.
I read somewhere, first of all, the book Mindset talks about growth mindset and fixed mindset, something I wasn't aware of. And I tried to teach my daughter, if you failed, basically means you worked less hard. If whoever got higher marks probably worked harder. So I know you're smiling, probably is wrong. but the point I'm getting at, they say, don't tell you are the best, or
yes.
Rather encourage, or how do you call it? Value the time that they still, like, tell them you worked very hard for this.
Correct. Yeah. I'm not saying that we shouldn't kind of push and we shouldn't ask children to persevere and to try harder. That's really important, right? And that's why you need the caregiver to be able to say, no, I know you can do it. Try it again. This didn't work well. Have you tried it this way? Or this is something you're not good at. Let's practice it. I'm not saying we don't need to do that. But everything is a delicate balance. We can't be so rigid in saying this is the expectation of what a child must do at this age. And if you don't do it, it means you're not trying hard enough. And this is the consequence. Do you get what I mean?
Okay.
And also because children are different. Children are really different. And we really have to hold a mirror to ourselves and ask, what are we expecting children to be good at? Do we think someone is intelligent just because they're good at maths and science? Why don't we value that actually being creative, being a good artist, being thoughtful, being kind is actually quite an important life skill to have? May actually be better than whether you can say your, 5 times table in 30 seconds or something like that. So we really have to be able to,
Very true.
navigate that it is about our expectations versus recognizing what children are good at and, urging them to develop that skill versus recognizing what they may be less good at and not making them feel bad about it.
Before I go to the next question, which is only the second question, how, I don't know if say this is you or whoever, how are we going to implement these things to teach parents?
I think this is a good start because it is about how do parents consume information and from where?
Social media.
Yeah. So this is all about education. And this is all about kind of having those hard conversations. It's calling it out in our social circles, in our friend circles, in our work environments. When schools are giving feedback, it's about calling it out. It's about asking, what have you put in place here to support, kind of whatever. And so I think it is about awareness. It's about talking. And it's about kind of changing the narrative in terms of what children do or shouldn't do. And I'm going to go back and forth to this all the time again when I teach. I always say to the medical students or the allied health, ask yourself what's the job description of that child. And our aim in mental health is not to get rid of all the symptoms to exclusion. It's to get you functional. I'm not going to give you medication to get rid of every single voice you hear in your head. If that medication has so many side effects that you can't wake up in the morning, that you've ballooned up, that you have a poor self-esteem and you can't go back to school, then what good is it that you don't hear voices anymore, but you're sitting alone in your room at home? I would rather that we work towards functionality. And you can only work towards functionality if you understand what's the job description of the child. So what do we want a child at this age to be doing? I want that 16-year-old to be arguing with you and to be, rebelling.
Give me gray hairs.
Yeah, and being able to say, no, I don't want to do this. Why? Because they are exercising their agency. It's, kind of independence that's coming out, their thought processes, they're questioning it. And that's what we want. We want there to be these kind of thoughtful, critical, reflective adolescents becoming young adults.
I'm just thinking of my own mistakes, telling my daughter, you do, like, I'm telling you this because I know better. So. I said so. I'm 3 decades older than you. But
the answers are not in a manual, right?
True.
Nobody knows.
True.
Nobody can come to you and say, this is the right way to parent. That's nonsense. You parent appropriately with your child for where they are at this point, but also be aware of what stuff you bring yourself.
Yeah.
What your own experience of parenting was like. And we need to catch ourselves, whether we're becoming our mothers and fathers,
Is it too late to rewire the child or adolescent? Or
No. So
Okay.
the WHO basically tells you that the definition of young adult or adolescence can extend up until 22, 23 years of age.
Okay.
And that's a really important thing to remember because your brain is constantly changing, right? And you have 2 growth spurts. So we've talked about in that first 1,000 days.
Yeah.
And then again in adolescence. It's why we have a
teenagers,
vulnerability in teenagers for their first expression of mental illness. It's why when we say, things could be okay, but then when you smoke cannabis at that particular point, if you have a vulnerability for mental illness, you're going to become psychotic. Whereas there can be 1 million people who smoke cannabis and nothing happens, right? It's about timing. And it's about growth and development in the brain at that particular growth spurt that happens. So what's also happening in the adolescent brain is apoptosis, which is programmed cell death, and synaptic formation. And so lots of things are happening and your kind of executive functioning is being developed a little bit better and more sophisticated, and your reasoning, your maturity, it's what we call about the brain maturity, your frontal lobe is developing. It's kind of why we have the highest rates of motorcycle accidents in that 18 to 21 year category, because they basically have problems with speed and depth perception. The insight and judgment is not quite. Yeah. And so if you read that, and I can't quote the exact stat now, but the neurosurgeons will tell you it's why we have, the highest rates of harvesting organs from these young children in the 18 to 21 category because they have these huge high impact motorcycle accidents because they don't judge. It's why these children shouldn't be driving smart cars at 19 and 20. That's bad parenting. Like, why are you rewarding them at that point with something that actually is quite dangerous? Because it's about speed. It's about why we don't let under 18s vote. It's why certain countries have limits in terms of when they can use alcohol, because it's about reasoning, it's about decision-making, it's about frontal lobe development. So to answer your question, can we change that? Yes, we can, because we can alter trajectories. We can shift it. And there are certain things that are stacked up against you sometimes, in terms of exposure and genetics. But that doesn't mean we can't change into a better trajectory. And that's why early intervention is so key and critical in children and adolescents.
And so what are the signs that parents miss?
So, like I said, what is the job description of your child?
So basically look at...
If that child is, say, an early teen, you ask yourself, what are they supposed to be doing, right? They want
in
friends.
The room alone.
Yeah, they can want to be moody, right? They want to be moody,
okay.
But they also want friends. They want to be able to communicate with others. They play sport, right? They want to do social stuff. They want to go to the mall. They want to meet their friends.
Exactly.
They want to do... When your child is not doing that, that's when your red flags should go up, right? Why is this child... all these children want to stay in their rooms, but every day, the entire weekend, are you not even being asked, can I go play soccer? Can I go to the movies? Can I go to my friend's house? Can I go for a walk? Can I go shopping? I want this tech device. I want something else. When they're not asking that, you should be asking yourself, why is that?
My child is doing all those nagging things, okay, so she's normal probably.
Yeah, right? And the same thing. So when we ask, what is an 8-9-year-old supposed to do? They want to go to school. They want to play with their peers. They want to color. They want to, kind of play whatever, Minecraft or whatever it is they're doing. When they don't want to do that, that's your red flag.
What's the difference between normal behavior and warning sign of something more serious?
So what you're asking is normal versus pathology, right?
Yeah, so the normal is this one's you just explained now.
So even in pathology, people often ask, every time something is outside of normal, right? It's when something is persistent and it is impairing. So when symptoms persist and they impair your normal functioning, then it's pathological.
Basically the daily activity. Okay.
Yeah. And so even in that, there's further to that. So you may have ADHD, for example, and you may not be impaired in your environment. So this child might recognize, I can't sit for 30 minutes. I can sit for 20 minutes. Then I must run around the table and expend that energy, and then I can sit down. Or they might say, I do better when I'm tired. So I need to run and do my physical exercises and then sit to do my homework.
So they function.
Or whatever. So they function better, but it's not impairing enough to require medication or intervention in that way. And that's how we decide what intervention to give. So not every child, and I use ADHD because it's a common example, not every child who has ADHD is impaired. Not every child who is impaired with ADHD needs the same kind of treatment, if that makes sense.
Yeah.
And the treatments may be very different. So I will often get asked, parents will say things like, can I change the diet of the child, right? And maybe my child needs to eat less of this, more of that, or whatever. And I say, go for it, right? Because if it's impairing enough and it persists, you will need the intervention I'm suggesting.
Okay.
But if you decide you want to change your child's diet and give them more nutritious and healthy foods, please do that, because children eat nonsense on a daily basis, right? Your chicken nuggets and bananas are not going to cut it.
True.
Yeah.
The chicken nuggets, yeah.
And if you say, oh, but doctor, can I try, a vitamin elixir? Like you get all these vitamin thingies. And I say, absolutely, do it. Most children's brains are not well nourished. It doesn't mean that two things can't be part of an intervention at the same time.
Totally agree. Not big fan of multivitamins, but when I see my child only eating chicken nuggets and cheese toast, whatever.
That's right. That's right.
And
so the intervention then is targeted according to the level of impairment and how much the symptoms persist. And so that intervention itself may or may not remain the same going on. So we often will see children require more medication, for example, the younger they are. When they're older, they recognize their deficits better. They know more what works for them. So they require less assistance sometimes with that. And so people ask, and they make the false equivalent. They say, well, if the child is older and weighing more and needing less medication, it must mean they didn't really have ADHD. Not true at all. Just means your adaptation changes, your brain changes, and your ability to navigate around that and make adjustments improves. So,
Now I'm going to go to suicide. And the question is suicide really a choice? Or is it a product or a symptom of something bigger?
I think it's hard to answer as a blanket yes or no. Okay. It isn't. I think that there are many factors that influence suicide and why people attempt, especially children and adolescents. I think one of the differentiators, importantly, is that not everyone who is depressed attempts suicide.
Okay. And
not everybody who has completed a suicide has been depressed either.
Oh, okay, I see now.
So people may attempt suicide or self-harming deliberately for a variety of reasons that may not necessarily be related to mental health.
Okay, I see where you're going. Okay.
And those would be psychosocial risk factors. It could be vulnerability. It could be trauma. It could be, kind of financial difficulties. There are a number of reasons, and there's a lot of literature around that. But it's also not necessarily as it's typecast as, somebody who has no trauma history, who has no history of psychosocial disadvantage, may also feel suicidal. So I think it's a little bit more complicated than that. Mm-hmm. When we look at it in children and adolescents, there's also a sense that children have responses that are varied, and how they respond to stressful situations or situations in which they feel helpless and hopeless and unable to manage will rely on how the caregivers navigate that for them. So when there are, for example, let's take bullying, which often happens where children are viciously bullying. So there are roles to be played by the schools, by the caregivers, by the adults in the environment, by the other children who also on look, that contribute to it. And I think that very often the children we see are really facing such dire psychosocial stresses. It becomes difficult for us to pinpoint and say, oh, well, if the school did a better bullying program, anti-bullying program, this wouldn't have happened. I think they're multifactorial. What we're notoriously bad at is not checking in on where children are and assuming that one particular intervention works for everybody. So again, it's, people say, how did I not see it?
Are there symptoms?
What are the risk factors?
Risk.
Right? And so the risk factors are obviously mental health issues if you've had a family history of it. Psychosocial determinants are hugely overwhelming. Children who feel helpless, who feel hopeless, children who are in situations from which there appears to be no respite. Abusive homes, but also difficult, dangerous environments, being in the space of caregivers who themselves are quite traumatized. All of these are risk factors for children. Untreated mental illness in the caregivers, untreated mental illness in the child, psychosocial environmental risk factors, like children, for example, who feel like they can't they're not heard, they aren't able to perform at school, quite punitive responses at schools, for example. We talk about peer pressure, but what do we mean by that? We mean kind of pressure to conform, exclusion, online bullying, which we don't talk enough about. Cyberbullying. And then access to care, which also makes it hard. So you can have all of these things, but if you don't have the opportunity to be able to navigate this through, whether we say counseling or support or school intervention or parenting or psychologist or whatever, then those things stack up against it. So think of it like a Rubik's Cube.
Yeah, of course.
It's not just one thing. It's not like in adults sometimes where, there's financial distress and, for example, they see no end and they protect their families or whatever. That's a different conversation. For children, it's often a variety of risk factors, most of all based in the immediate home environment and how well they feel able to access care, whether that is via the caregiver who can scaffold or via the responsible adult that they feel safe enough to do it. Problematic, obviously, when that caregiver is the person that is, abusive or neglectful or having their own mental health issues. It's very difficult.
So if my child, for example, is bullied and I'm not aware of, and she's not one of the type of person who would speak up, are you saying, okay, the best way to look for signs, would it be to see if my child doing the same thing she was doing before?
Correct.
That would be like one of the best.
One of the best things. Is there a change in functioning? That's what we mean. Do we notice the change? It's not so much what they say, it's what they're not saying, or what they're not doing. Is there a change? Are they refusing to go to school things? Are they refusing to take part in stuff? Do you see less friends coming over? Is the child withdrawing, isolating? Is there academic decline? If we're only looking for a child to be tearful and depressed, we're going to miss it.
Okay. I've talked about addiction, I think once or twice on my social media, and people say it's a choice. And I know it's also a mental health issue. Is it a choice?
No, I think it's physiological. I think that children, there's a vulnerability. So, for example, some children may, be tempted or may use it. You use it once, you try, you experiment, part of your developmental trajectory, nothing happens. But for other children, it could also be that is the trigger factor. When we psychoeducate about, we talk about dual diagnosis, the coexistence of a psychotic illness or a severe mental illness and a comorbid substance use disorder, like cannabis or methamphetamine or alcohol use. Not everybody who smokes cannabis becomes psychotic, for example, in adolescence. But there is a proportion of children who have a brain vulnerability. So that is about those early adversities. So if you've had a head injury, if you've had intellectual disability, if you've had something that alters the kind of, the integrity of the brain physiologically, then if you have a genetic vulnerability for mental illness or for substance use, if you've been exposed in utero, if you've been primed in that way, then you are more likely to have, that trigger, an expression of mental illness at a particular stage in adolescence than if not. So it's not a simple thing as you have a choice, you don't have a choice. Most children do feel pressurized into experimenting with substances, but most children don't develop a substance use disorder, a dependence like we call it, which is the addiction we're talking about. But you do have physiological vulnerabilities to that. It's kind of like when people take ADHD medication to neuroenhance rather than to treat ADHD. They think they're going to help them to do better at school, right? And so people will say, well, you can be addicted to it. And their response is, well, children, millions of children are on ADHD medication for ADHD and they're not addicted. And my response is, that's right, because it's there treating a particular condition that has a particular neurochemical response that is required. You don't know when you take that stimulant drug for a reason other than what it's prescribed for, that it isn't going to trigger for you your vulnerability for psychosis or addiction. And in fact, the literature is unequivocal about the fact that if you are treated for ADHD, you have a lower risk of developing a dependence than if you're not. And the reason is simple, because when you're not treated for it, you seek out medication in other ways. So you seek out a stimulant, you seek out some other drug that will help you treat that.
What is addiction? When you say I'm addicted to my phone, or addicted to social media, or addicted to porn, or addicted to masturbation, for example, lots of sexual health.
It's a physiological response where you are priming up your reward pathway, which is your ventral tegmental axis and your dopamine reward pathway, where suddenly if you have a hit for something, like for example, you're in love and it primes your dopamine reward pathway, and then you seek more than that. And when you seek more than that, you seek a substance that basically works in that pathway. I'm explaining it very simply here. Yeah. After a while, the same amount of something doesn't give you the same high.
True.
And so that's what we call dependence, where you need more of something in order for you to get that high. And when you don't have more of something, you get withdrawal from that. So it creates a substance use disorder physiologically. And it's not easy. to kind of just stop it like that. Now, similarly, we use that model of dopamine reward pathway to explain other forms of addictions. That basically physiologically, you have this desire physically for you to get that high or that kind of spurt of response for certain things. So be that porn, like you said, or, addicted to social media, and you find it difficult to stop because your brain is like kind of sucking up more and more and more of it and getting used to that dopamine surge.
So one sign would be like if it's affecting your daily activities.
Remember what I said, it's impairment and it's persisting. So the minute you're impairing and you're unable to do anything else, then you're on your trajectory negatively.
I must go diagnose myself. I'm addicted to my phone or not.
And that's right. That's exactly it. And there's a lot of literature. I'm not the expert in that, but there's a lot of literature around gambling addictions, around sexual addictions, but also social media and internet addictions that children find it harder to just stop. To just put it. But it is about limiting access. It's about putting those boundaries down early on before they are kind of priming their brain to like certain things. So sugar, is also one of those things as well. So it's about what's giving you that high, what's pushing up your dopamine release. That feel good,
Exactly. My next question is what common mistakes parents do, even like they mean well. It's to limit.
Correct. They aren't predictable boundaries and they aren't limit settings. So limit setting is really helpful for children and for adolescents because it helps them to almost anticipate what's the end result. And anticipating that makes you feel safe as a child because those are the boundaries for what it is. It allows you to explore better, and we explore to learn. And we can only do that if we feel safe. But if there's just chaos, you don't know if anyone's going to stop you or anyone's going to help you. It's very hard for you to explore the environment and learn from the environment. So the boundaries and the limits are there for the child, not just the way we see it so simply as it's I'm punishing or I'm disciplining. The boundaries and the limit settings are there to facilitate learning. Think about it. When the child is going to the beach and before they run to the waves, they look back to look at the parents. And the parents, it's okay, go. It's all right. I'm right behind you. Or do you want to try going onto that jungle gym? It's okay. I'll catch you if you fall. You're putting a boundary. You're putting a limit. You're saying, I'm not just letting you go out into the free world and, sort yourself out. It's, I'm going to be there. I'm the adult. That's attachment theory. That's basically saying I'm creating a secure enough base for you to go out, explore, and come back. I'm going to be there. If something happens, I'm going to rescue you. And that's what children need. That sense of safety, which comes from predictable boundaries. And then it allows them to explore. One of the things, and maybe that's a good point to like kind of put things in perspective now of everything we've spoken about. So John Bowlby talked about attachment theory. And so we make a mistake and we say attachment means bonding. It's love. It's not love and it's not bonding. Attachment is that idea or the awareness that the infant has where they seek out another clearly identified individual, usually an adult, who they perceive as being better able to cope with the world than they are. So think about that for a moment, right? It's seeking out a relationship with another clearly identified person who is perceived as better able to cope with the world than they are. And so what that means is you don't need to be that perfect person. You don't need to be the one who's got all their stuff together. The baby needs to believe that you will take care of them, that you will sort it out. Because what that does is it allows them to trust. And the trust in that relationship is what allows the baby to then walk, to fall, to explore, to run, to learn, to do that. Because you trust that there will be safety, that there's a limit, that no matter what I do, that adult is going to sort it out. It's the same thing for adults, right? You need to trust in that relationship with the others, that they'll be there when I'm falling apart, when things are not okay. They're not only going to be there when things are all right.
True.
Right? And then it allows you to be vulnerable. It allows you to show the worst sides of yourself because it is about the unconditional acceptance of it. Of course, love is important, but that's not the basis of it. Okay. Right? And so it's one of the reasons we would say your child shouldn't automatically think that they are your best friend because a child also needs a parent. right? They can't be held with that responsibility to hold your adult stuff as well as their own. So yes, of course, we want to be friendly with children. But I often get mothers say that, oh, my daughter, we like besties. No, I'm sorry. Your child has besties her own age.
True.
She needs somebody who she can trust. Then when things fall apart, you will come.
Oh my God, I'm learning a lot.
You will do that.
I'm learning a lot. I have lots of myths here. I feel like we have covered most of them.
Mm-hmm.
One of the ones that I've been told by colleagues or parents is that they were put on medications, and medications make them zombies, or you guys put doctors, psychiatrists put people on medication to make them zombies or something like this.
I love that question. You're probably right. Then I'm treating something that's not treatable, or I'm using a medication for a reason it shouldn't be used in, right? I'm using it to treat something that's not impaired. I'm giving you medication that actually is not indicated because the indication is more psychosocial. I should be asking for support for the parent, but instead I'm medicating the child. So yeah, I agree with that. I feel like medications used for reasons other than what it's meant for will of course make your child a zombie. But if you've ever seen a child with ADHD finally receive medication and thrive, you will not see a zombie.
Okay.
But you will see a zombie in children who are being medicated for other psychosocial reasons, which have to do with boundaries, which have to do with limit settings, which have to do with psychosocial adversity.
I see what you're saying. Okay. Make total sense. Next one, it's very popular around Andrew Tate cult, that if you have mental health issues, mean you're a weak person, and if you're a strong person, you're just gonna outgrow it or go do some gym and dumbbells, whatever, and you're gonna be fine.
I think in a more nuanced way, what he's trying to say, and I'm not a fan, and I have issues with that, but it's about whether physical health actually can overcome mental health issues. So if you are physically stronger and active, then you actually don't need medication. That's a very simplified way of thinking about it. In a way, it's correct. Sometimes you might, physically need to be moving for your mind. We often say move for your mind. Having said that, I never quite understand why it has to be either or. Why can't two things be true at the same time? Why can't you do your reflection, your quiet time, your yoga, your running? Why can't you be engaged in meaningful weight training and run a marathon and also be in therapy and get treatment for your mental illness?
I don't know if you know, I was chosen as one of TikTok's mental health ambassadors, and asked me questions, interviews when I was announced, and I used to tell them mental health and physical health is like two wings of a bird.
Correct.
If one of them is issues with it, you cannot fly. You cannot have the life quality that you want to. Okay, so another myth that they say you can tell if someone is depressed by how they look.
There's depression. And then there's mild, moderate, and severe with levels of impairment.
Okay.
So you can be mildly depressed and quite significantly impaired.
Okay.
Right? And you can be severely depressed and still continue with your work every day and not seemingly be impaired in that. And so I think that it is a difficult one, especially mental health care of adults, of professionals, of men, that we don't talk a lot about. And there's this really toxic masculinity around what we think being vulnerable means, right? And acknowledging that maybe it doesn't feel right. Why am I not feeling so, kind of wonderful and buoyed up if all these wonderful things happen? And why is it that I'm so ungrateful for that when other people are really struggling to get a job, struggling to get their breakthrough? And so what these are negative cognitions. And it's also this false separation, this dichotomy that depression only affects people where things are going badly, right? People become depressed sometimes. Obviously, it's a biochemical inflammatory condition, which has a neurobiological reason for it. You wouldn't ask yourself, why, if I've run Comrades Marathon 3 times, I don't smoke, I'm vegan, and I had a heart attack? You're not like,
True.
Oh my God, why are you so weak? We don't say that.
Very
we say,
true.
well, these things happen. It's your genetics. It's not one thing, right? If it was just one thing, we would correct that. We wouldn't have, like you say, this pandemic of mental illness. But it's so complicated. And it's about us, number one, not allowing ourselves to acknowledge that mental illness is not a discriminator across professions or genders or privilege. That's the first thing. And the second thing is we're so hard in terms of what we allow ourselves in terms of exposing vulnerability. You can be extremely high functioning and also need to be in therapy. In fact, child psychiatrists are almost all by default in therapy themselves because there's a lot of stuff that we hold, right?
I was thinking about the same.
Yeah. And I think one of the most, I had a mentor once long ago when I was training who said to me, at some point in your life, allow yourself the luxury of therapy. And it's one of the best things I ever did. I've never had a diagnosed mental illness that I've needed treatment for, thankfully, in my lifetime. But I've had several not so pleasant experiences. And, I've had a mother who had dementia and who died from it. And it's very hard to watch people become less of a version of themselves. And so all of those are reasons you would engage in therapy, which is important and meaningful. And you can't be the best version of yourself if you aren't aware of what is the stuff you bring from your own childhood into this, your own expectations, unrealistic or otherwise, but allowing yourself to do that. When I told somebody at work that, I can't make it this day because I have my therapy, they were like, Anusha, I didn't imagine that. Are you okay? And I've always been okay. But I like to think I'm a better version of myself.
Exactly.
Because I allowed myself to kind of unpack a little bit. And it's still a process and it evolves over time. And so to answer your question, it is masked because we deny ourselves the opportunity to be truthful. We also feel like if we're struggling, we either must keep it quiet or we must share it with the world. There's no recipe for that, right? People say, he's such a wonderful person because he at least shared his mental health struggle. You don't need to do that. You need to seek the help for yourself and for your intimate connections around you and relationships. And anything outside of that is a privilege to other people, right? And so it is many times professional people feel, if I name this condition, then I have to share it with everybody. And maybe I'm not ready to do that. And maybe it comes with judgment, which it totally does, right? And maybe people will think differently of me. It's really such a personal experience to have. People who come out of it, who are able to talk about it, I always say a gold star for that because you're helping break the stigma of it.
Exactly.
But at the same time, who died and made you in charge of everything? That you have to save everything and everyone. So that would be it. I think especially men's mental health is not spoken enough about, and that's because we have unrealistic expectations of what they should or shouldn't be doing. You should be stronger. You should be getting your stuff together. You should be grateful for all the stuff you have.
How can one person take care of their mental health?
I think it's allowing yourself grace. That when things are not okay, that you need to be able to share that. And that doesn't mean you have a mental illness, but it's about asking for help. It's about putting a boundary down. It's about saying no. It's about recognizing when you need a break, or it's about recognizing that maybe sometimes it's too much. I thought I could handle it and I can't. And that's why we're not an island, right? And that's why we need friends and we need peers. And if we don't have that, we also need a therapist, or we need somebody that we can trust, that attachment figure we're talking about that can help navigate it for you. And that can also be the person that says to you, you know what, I think this is a little bit more to it than now. Maybe we do need to see a doctor. Maybe we do need to see a professional. Maybe, this might help. I think the idea that we protect our mental health alone is another myth we need to bust.
It's the first few words that you mentioned. So once I was diagnosed, obviously I was on medication for 3 months just to lift up my mood so I can take care of myself. But what made me recover from it was to put boundaries and say no at work, basically. Because I was trying to save the world and I was doing that and I realized it's not my job. Once I realized that, I put boundaries. I learned to say no because I want to help everyone.
It's hard to say no. It's really hard to say no.
Yeah.
And especially in places that we work in and in the field that we're in, it's also about opportunities, right? And you don't want to say no to opportunities. But at the same time, it's about a delicate balance.
I've learned, I was telling one of my colleagues yesterday, I've had big brands, international charities coming asking me for free content. And I was like, my mental health is not for free.
Yeah.
Yeah.
Well done.
I was so proud of
Well
myself.
done. Yeah.
But if they asked me at the beginning of my career, social media career, I would have jumped on it. But
Yeah.
at some I realized, boundaries. See, I'm also learning. How apartheid is affecting children's mental health today?
Such an important, loaded question that's so hard to answer in a simple way.
Okay.
But what I would say is that we are a product of our relationships and our communities. And as parents have been, I myself grew up in that time, parents who have experienced unacceptable levels of trauma, of disadvantage, of exclusion, are not going to sit up one day and say, I'm over it now because I live in a free South Africa and I have equal opportunities. It's not true. You know, there's always that like kind of cartoon about the difference between equity and what is, kind of what is equal versus what is equity.
Yeah.
And that's such an important thing for us to remember, that if the adults have not processed and have not been able to speak their own truth and narrative, it translates out into children. I'm also not a fan of people saying things like, well, everybody suffered. No, everybody didn't suffer in the same way. People were disproportionately affected. As much as I may have grown up in an Indian community, which, in a state-aided Indian school, and not have had those opportunities, I am very aware of my privilege and have had so much more opportunities than my Black colleague counterparts who've had a very different upbringing. And so I feel like if we can't speak about this out aloud, and if we falsify the narrative and we say, well, everybody suffered, everybody's disadvantaged, you often will hear that. Why must my child suffer now for something they didn't do?
I hear that a lot, yeah.
Or why must my child suffer for something I didn't do? I didn't go in and sign to make people have passes and whatever. No, you didn't. But you were part of a community and a legacy that hurt, that disrupted, and that disadvantaged. And for as long as we can't have that respectful, meaningful discussion, your children are not going to. I want to say on that, one of the pet peeves I have is where people say, my child doesn't see color. Have you ever heard people say that? Oh, yes. That is so not true. Babies, as young as 3 months, can differentiate color and symmetry. So you cannot sit here and say, my child doesn't see color. Your child does see color. What the color difference means is a different thing, right? So if you are in a household where you're saying, oh, we're all the same, a 3-year-old is not going to believe you because you and I are 2 different colors, right? The child in a class, I've got straight hair, somebody's not going to have straight hair. For you to say we're all the same because we all look different is kind of not giving your child the right message. What you need to do is you need to be able to process that for the child, that we are different in the way we look, but not different in the way we think and feel and the things we deserve. And underneath, there's that lovely saying from the geneticists in Africa at the kind of Wits Center for Human Research, and they always say, we're all African underneath the skin, right?
Okay.
It's where mankind originated. And that's an important, powerful point as well. So I think my message would be also to not give a false narrative for a child. You have to help the child distinguish. People look different, right? But different doesn't equal inferior.
But we all flowers of one garden, basically. Yeah.
It's about difference, There's diversity and there's difference. And it's not necessarily a bad thing. But whitewashing it, literally, and saying we're all the same. I'm sorry, we're not the same. The 2-year-old that's dark-skinned is very different from the 2-year-old that's blonde and blue-eyed. And they need to know that just because you look different doesn't mean one is better than the other.
Of course. Is mental health a privilege in this country? Like, is it? Well, I feel like, well, it is.
Well, it's not actually, because how do you access care for mental health services in South Africa? The answer is very poorly, regardless of your medical aid scheme, regardless of what access you have. I mean, even if you look at it, there's such a disparity. We call it the parity of disease, right? If you are medically unwell and if you need a heart work for a cardiovascular condition, right? You're going to get so many units of time available for you to see the cardiologist, repeat, see the cardiologist. Let's do an EEG. Oh, he wants an echo. Oh, she wants to do more bloods. Let's follow you up. Let's do an ECG on a treadmill. All of that is covered. You try doing that for mental illness. If I've just told you anything today, it's about how children are different, but mental health looks different at different stages, right? Whereas 5 sessions of psychotherapy may be okay for a mild depression, 5 sessions is not okay for a moderate depression with trauma, with ADHD, with the parent that's dying of a terminal illness, with a demented grandparent. It's difficult. And our access to mental health care and services is shockingly bad in South Africa. And I'm not even talking about poor people. In fact, I think people who have to access in certain public health centers have maybe a better opportunity to getting care than people in private practice.
True. Thinking of it that way, yeah.
Right? Because you have restrictions in terms of categories of what is considered a prescribed minimum benefit, in terms of what, kind of actuaries or decision makers who plot and, mold these kind of trajectories for what is covered and what's not covered. And so access, the bottom line is access a privilege? It shouldn't be. But is it a privilege in South Africa? No, because even those on medical aid insurances don't get the quality of care that they require.
Thinking about this, I have in my comments people from the US asking me if there's any online services because they also struggle to get...
And in the UK, it's not ideal, And so I think there are many answers to this question as to why that is so. Firstly, our awareness of mental health is shockingly bad. Yeah. How we proportionately allocate funds, also shocking. And that has to do with mental health stigma and what we think mental illness is. And people who are dangerous or who are disordered, who have psychotic illness, is a very small percentage of the proportion of mental health issues.
That's exactly how we thought as a child. If somebody had mental issue, somebody psychotic running around the street.
That's right.
That's what we thought.
I mean, schizophrenia has a prevalence rate of less than 1%. Right? So what about the rest of it? It's far more common for you to be depressed, for you to be anxious, for you to have the complexity and the responses post-traumatic events, for you to be living in a country that is dangerous, that doesn't have enough food all the time, that, we have, look at the things we live with, potholes, blackouts, load shedding, kind of we run out of stuff all the time. Corruption, children, where have you seen children waiting to go to school for 2 years when there's no place in the public school, right? What are we doing? We have stunting. We have, if you look at intelligence markers and IQ, we're less cognitively than anywhere else in the world if we have to compare equivalent spaces and economies. So no, it's not a privilege because we don't have that privilege. And it's also about how are we able to train people? And when people train, where do they work? People, there's no posts, there's no opportunities.
That's my next question. You are one of 35 child psychiatrists.
One of 35 child psychiatrists in the country. How? 16 million population under the age of 18. How?
Wow.
What child is going to have the privilege of seeing a child psychiatrist, right? It's not okay.
Is it because doctors are leaving, or is it there's no posts, there's no funds?
I think there's a multitude of reasons.
Okay.
One is there is not enough funding and commitment towards training people in particular specialties.
Yeah.
There are not enough doctors. There are also not enough allied or any associated healthcare providers.
Yeah,
Number two, if we rely only on doctors, that's a mistake, because doctors are high top tier service providers. That's not where the bulk of children or people need to be seen, right? So that begs the question, where should children, adolescents, and their parents be seen? They should be seen at primary healthcare centers. They should be seen by nurses, by medical officers, by allied health. What is the problem? People refuse to see children with mental health issues, right?
We don't know also.
They're happy. They're happy to see babies who are not thriving, who are not eating, but they're not happy to see babies who are spinning tantrums and, kind of aggressive, children who are falling behind on their developmental social milestones. And so we don't train enough. We don't train those who are trained properly in mental health. Mental health is not a fundamental part of even national nursing curriculum. And you think, how? Why? They can read ECGs, but they don't know what to do with depression, which is far more common.
Put chest tubes in.
Yeah,
resus.
How? And if we look at a country which has a burden of communicable diseases like TB and HIV, the non-communicable diseases are the third leading causes of death, right? Why are we not training people in that? How can you honestly sit here and think that you can have TB, a chronic illness, take that medication for 6 months, lose weight, be off your job, live in difficult situations, and not have a mental health issue? Really? How can you have HIV, which affects your life on so many levels, not have a comorbid mental health issue?
There are risk factors, chronic conditions for mental health issues, right?
Absolutely, but we don't train them adequately. We don't equip people who are providing physical health care to be able to treat mental health issues. And of course, the last kind of, bee in my bonnet that really annoys me is about the active poaching of our doctors and our specialists from high-income countries. Look at Canada, Australia, New Zealand, the UK.
Ireland, yeah.
It's shocking. And we don't blame the doctors for going because, you want to live in a safer country, you want to earn more money. But I feel the responsibility also lies on these high-income countries to be able to look at where their moral compass is. Why are you draining us from a poor country, with, our doctors are well respected internationally, come with a good skill set, but where's your moral compass to not offer them that, diamond encrusted carrot? So there are many reasons.
What made you choose psychiatry as a specialty and why specifically child and adolescent psychiatry?
I always think that's not an easy question to answer. I was always interested in pediatrics more than I was interested in psychiatry. And I never had exposure to child psychiatry in South Africa until I worked overseas for a bit. And I thought child psychiatry is a lovely blend of us understanding children in more than just a physical way. So I have no regrets.
What's one moment that changed how you practice?
That's such a hard one. It wasn't one single moment. I think that being a child psychiatrist is a very humbling experience. And you don't often understand how children see you. When you kind of, I'll give you, it's such a funny, silly example. I was working in Tygerberg at the hospital and in child psychiatry. It was many years ago. I was just starting off and I think it was particularly not a great day, and I was like, things are not working out and I can't remember what the reason was, but I know that it wasn't great and I wasn't feeling my best self. And I walked into outpatients, which is like in a dungeon, a way, where mental health is where, children must not be seen. And so I'd walked into the outpatients and there was these two girls playing at the bottom in a very basic minimalist waiting room. And they were coloring in something, I don't know what. And then when I walked in, they must have been about 7 or 8 years old. And then they stopped and they were like, ooh la la. And I always laugh, and now we tease each other that in outpatients about ooh la la. And then she said, oh, she's like a Bollywood star. And I was like, what? And it was myself and it was a matron in charge. And the way we laughed, and the matron said, what did you just say? And they're like, look at her hair and her lovely shoes. And she's got such expensive clothes, And we had a laugh at that moment. But for those two little girls at that point, I reflected on that many times in many different spaces about how I hadn't thought I was the best version of myself. But to little girls looking at me, suddenly I was like a Bollywood star for them because I had long black hair and I had nice shoes and pretty clothes. And that's what they saw, And sometimes it's a very humbling experience because we judge ourselves so much. We don't allow ourselves some grace. And when you work in these situations of absolute dire neglect and need, you forget sometimes.
True.
To kind of be appreciative for little things. And I always think about that, like if I'm flicking my hair, somebody thinking I'm like, and that's all they saw.
Yeah, exactly. Yeah. So, last two questions. There are more personal questions. I usually ask my guests, what advice you would give to your younger self?
Not to sound like a beauty contestant, but I would say give yourself some grace. That it's okay to sometimes try things and be wrong. I was so afraid, I think, early in my career to ask for stuff and to try things because I thought I'd be wrong or somebody might think that's just a rubbish idea. And 20 years later, I can tell you in my career, which is like going to be close to 25 years now, I would say I wish I'd asked sooner for more. Because now in the last 10 years, it's random things I'll encourage my students, mentees, and I'll say, the worst that can happen is someone will say no.
Exactly. Yeah.
And then if they say no, they say no. And so far, very few things I have asked for, and I'm talking career-wise, have been, denied.
When I was med student, my friend said, if you don't try it, the chance of you sitting for an exam. So my friend said, if you don't come to the exam, the chance of you passing is 0. If you come, there's 1% chance.
That's it. That's exactly it.
Try it. You never know.
Yeah, I mean, when people look at things as if you just look at the CV or the kind of stuff we do in the field, it's a lot of it is bringing us a lot of joy and it's groundbreaking sometimes when you think of what our students are doing or, what we're committed to in our infant mental health field and our spaces and stuff. I can tell you 90% of that stuff was not your normal trajectory. It was, we took a chance, we went to the VC or we went to the dean and we said, why don't you want to do this, or I kind of, you submit something in a different way and you say, let's take a chance. It's not what that grant is asking for, but let me try. And you never know. People don't know what they don't know. And you have to be confident enough to not be afraid to fail.
Yeah, that's what I do bets with my daughter to do something daring.
Yeah.
So I try to push her, maybe go shopping alone or go restaurant with her friend just to...
I want to tell you, you're making me think now, if I go back, everything comes back to babies and children and attachment. And what's the strength of a good relationship? What's a sign of it? It's not about how much love, again, there is or how wonderful you feel. It's about how quickly you can repair. So when things go bad, how quickly can you repair? How can that survive? That reparation is what will signify the strength of that relationship.
Oh.
It's easy to be nice and lovely and, warm and it's all wonderful dopamine. But how hard is it to repair? Because the strength of the reparation, which comes from attachment theory, how quickly when the child is mad at the caregiver, can they repair and revert to that trusting, safe relationship? That is what you're looking for in a relationship. Strength of repair.
Last question. What is your biggest regret?
I think a little bit like I've just said, it's not taking a chance more often.
Not taking risks?
Yeah, I think I'm very risk averse. I've always been very risk averse, very compliant, kind of do the right thing, or what I thought was the right thing. But I do feel like I wish I had taken more chances earlier in my career, to kind of push a little bit of a boundary. But I think that comes with age, maybe that confidence that comes that I would have tried a little harder to do it. But if I had to say that I don't know people who say they have no regrets. That's not me. I have lots of regrets about lots of things.
I
know. But, some a little bit worse than others. But I think if I think professionally, I wish I had taken more chances earlier because I think I was so afraid, so afraid of not getting it or not, being sort of supported that I just stopped taking the chance.
Finally, before we close down, if you could give 2-3 advice to parents who are watching, what you would give? What you would say?
I would say is that your child didn't read the manual. And so you should really catch yourself from parenting according to a manual necessarily. I would also say is that be kind to yourself. Not everyone has their stuff together. So the kind of stuff you think everybody else is doing well, it's only the surface of what you're seeing. Most people struggle.
True.
And there's no such thing. Maybe my final word is, and this again is coming from attachment literature, there is no such thing as the best or perfect parent. It's just good enough. Mostly okay. Nobody is okay 100% of the time. And what your child needs is a good enough parent. Not perfect, not the best.
Wow. Dr. Lachman, thank you very much for this informative podcast. I personally learned. I always learn from the guests, but I feel like I rewired some of my brain.
Thank you for the opportunity. I enjoyed it.
It was lots of fun. Thank you.
Very nice.